Hello, my dear friends, and once again we're going to talk about one of the most important subjects in the neuroanatomy, which is the anatomy of the fourth ventricle. And you will see its importance right now. It's not a long subject, but it has to be understood and studied meticulously. So the fourth ventricle, as you all know, has a floor which is called the anterior wall or the ventral wall, which is rhomboid shaped, and the roof formed of the superior and inferior medullary villi and the cerebellar peduncles, and lateral walls formed of the cerebellar peduncles. So floor, roof, and lateral walls. It is tent-shaped space containing CSF, located behind the brainstem and in front of the cerebellum in the posterior fossa. It extends from the cerebral aqueduct above to the obics, to the central canal of the spinal cord below. And it extends laterally, having lateral recesses between the inferior cerebellar peduncle anteriorly and the flocculus of the cerebellum posteriorly. So, lateral extension is called lateral recess, having the inferior cerebellar peduncle anteriorly and the flocculus of the cerebellum posteriorly, as we will soon see. And it contains, of course, choroid plexus, and it communicates with the subarachnoid space by a median aperture called the foramen of Magendie and two lateral apertures called the foramina of Luschka. This is the classic sagittal view of a brain, and here you see the third ventricle, the aqueduct, and the fourth ventricle. As we said, it is tent-shaped, having a floor, anterior or ventral wall, and a roof, superior medullary velum, inferior medullary velum, and with the cerebral peduncles laterally. This is a view of the floor. We'll discuss it in detail, but this is to show you that the floor of the fourth ventricle is made from the pons, posterior surface of the pons, and the posterior surface of the upper medulla, and both are separated from each other by the stria medullaris, as we explained in the anatomy of the brainstem. So it is composed of three regions: upper region, intermediate, and lower. And of course, this is a view, cadaveric view of the roof of the fourth ventricle after we removed the inferior and superior and inferior medullary villi, showing the choroid plexus inside the wall of the fourth ventricle under the roof. It is T-shaped structure with one vertical stem and two horizontal stems extending in the lateral recesses, as we'll soon see. This is another view diagram showing that it is communicating with the third ventricle through the aqueduct, and downwards should be continuing with the central canal of the cord through the obitus. Not apparent here. And we'll discuss first the floor. As we said, the floor is made from the posterior surface of the upper medulla, what we call the open medulla. If you know, there is lower closed medulla and upper open medulla. So the upper open medulla and the pons form the floor of the fourth ventricle, and the upper medulla is low and the pons up. So as we said, the floor is divided into three parts: upper triangular part, which is the posterior pons, an intermediate part in between called the stria medullaris. Stria medullaris full stop, not stria medullaris thalami, just stria medullaris. If you want to remember the nomenclature, you go to the chapter of the thalamus. So here it is called the stria medullaris, and a lower triangular part, calamus scriptorius. So upper triangular part, lower triangular part, and intermediate part in between, the calamus scriptorius. Calamus in Arabic is the qalam, which is like a pen, the head of a pen, and you write with it, you script with it. So This is a global view of the floor of the fourth ventricle, and this is the upper part, and we get the strimedallaris here, and this is the lower part. So upper triangular part, intermediate part, and lower triangular part. The upper triangular part is formed from the medial to lateral, from the midline to lateral, by the median sulcus in the midline. Lateral to the median sulcus is the median eminence, and lateral to it is the sulcus limitans, then the vestibular area. We'll see it now on the diagrams. And in the superior floor of the sulcus limitans lies the nucleus locus coeruleus. It's a blue-shaped nucleus, and it is communicating with the pontine tegmentum, and it is related to pain. Nucleus raffimagnus and locus coeruleus. So it is present in the upper part of the sulcus limitans, and the median eminence, lower part of the median eminence, forms a swelling called the facial colliculus, which are the fibers of the facial nerve forming a loop around the abducent nucleus before exiting anteriorly or anterolaterally. And above the facial colliculus, the sulcus limitans forms a depression called superior fovea, and below it a very small depression called the inferior fovea. It's very easy if you see it on the diagram. This is a very nice diagram. We are talking again about the superior part of the floor of the fourth ventricle, which is made of the median sulcus. Lateral to the median sulcus we have the median eminence. The lower part of the median eminence contains a swelling called the facial colliculus, which is the loop of the facial nerve around the abducent nucleus. And lateral to the medial eminence or median eminence, we have the sulcus limitans, and the upper part of the sulcus limitans contains a nucleus called the locus coeruleus, and lateral to the sulcus limitans we have the vestibular area. So we are discussing the upper part of the floor of the fourth ventricle. This is a diagram showing the median sulcus, median eminence, sulcus limitans, and then the vestibular area and the facial colliculi. Another view showing it's not very clear like the first one, but a rough diagram showing the site of the locus coeruleus in the upper part of the sulcus limitans. And this is the facial colliculus. And this is how is formed the facial colliculus. This is the pons, the level of the lower pons. And you see that the facial nucleus is anterior and lateral to the abducent, and it forms a loop before exiting the anterolateral part of the pons, and this loop forms an eminence in the floor of the fourth ventricle called the facial colliculus. Again, you should say it, not me. Yes, the median sulcus, then the median or medial eminence, lower part of it facial colliculus, lateral to the facial colliculus the sulcus limitans, lateral to the sulcus limitans the vestibular area, and the blue-shaped nucleus locus coeruleus in the upper part of the depth of the sulcus limitans. This is the anatomy of the upper triangular part of the floor of the fourth ventricle. This is the intermediate part, and this is the lower part. And we talked about the upper triangular part. We talk about now the lower triangular part, which is the calamus scriptorius, as we said. And it is divided by an oblique sulcus running towards the midline from lateral to medial, dividing it into triangles. a medial hypoglossal triangle and a lateral vagal triangle housing the hypoglossal and the vagal nuclei, and lateral to them is the continuation of the vestibular area and the cochlear nucleus, as we'll see now. So it is continuous from the upper triangle to the lower triangle, vestibular area, but in the lower part we have, and also the cochlear nucleus. And the vagal triangle is further subdivided by a vertical sulcus called the funiculus separans. Lateral to it is the area prostrema. I know we have many names, but I assure you that these are the only names. We are not going to add more names. So it is relatively simple. Lower triangular part is made of two triangles, divided by the oblique sulcus. Medial to it hypoglossal, lateral is the vagal, and the vagal is subdivided by a vertical sulcus called funiculus separans. Lateral to it is the area prostrema related to vomiting. You know, this is one of the areas of vomiting. It is can be sensitized by the toxins. If you are having toxins in the blood from bad food you ate or something like that, this will stimulate the area prostrema. It has no blood-brain barrier and stimulate it to vomit to get rid of this bad food. Again, very simple diagram talking about the lower part. As we said, we have a sulcus running obliquely down to the midline, dividing the lower triangular part of the floor of the fourth ventricle into a medial hypoglossal triangle and a lateral vagal triangle, and the lateral vagal triangle is further subdivided by the funiculus separans, and lateral to the funiculus separans is the area prostrema for vomiting. Another view: upper triangular part, intermediate lower triangular part, vagal triangle, hypoglossal triangle, funiculus separans, and area prostrema. The intermediate part is a delicate band of transverse fibers called the stria medullaris, dividing the floor into an upper half which is made of the pons and a lower half made of the open medulla. And it is extending laterally as the floor of the lateral recesses. So the stria medullaris extends laterally to the cerebellar peduncles as the floor of the lateral recess, and we'll see why it extends to the inferior cerebellar peduncle laterally. And the stria medullaris is called the posterior external arcuate fibers, because sometimes you are perplexed by seeing some fibers called the external arcuate fibers, and some fibers on the posterior surface, the anterior external arcuate fibers are on the lateral surface of the brainstem. Posterior external arcuate fibers are on the posterior surface of the brainstem, and they run from the cuneate nucleus to the inferior cerebellar peduncle. If you remember the cerebellum, you know that the cuneate nucleus from the upper limb wants to give information about proprioception to the inferior cerebellar peduncle so that it can adjust the position of the body in space. Sense of position, sense of passive movement, sense of vibration, joint sense, muscle sense. So the fibers running from the cuneate nucleus, which is the nucleus of the upper limb, cuneo-cerebellar tract, is nothing but the stria medullaris. So what about the anterior external arcuate fibers? It has nothing to do with the posterior external arcuate fibers. It is passing from a nucleus in front of the pyramid in the anterior part of the medulla, and it passes laterally to the inferior cerebellar peduncle, carrying information from the pyramidal tract to the inferior cerebellar peduncle to tell them that we are working now and the pyramidal tracts are moving, so giving information to the cerebellum to adjust the fine movement and for coordination. So Posterior external arcuate fibers, proprioception. Anterior external arcuate fibers, fibers from the motor, pyramidal tract, and both of them end in the inferior cerebellar peduncle. To relieve all signs of perplexing, we have the internal arcuate fibers. These are the external. So the external are anterior and posterior. The internal arcuate fibers are those of proprioception in the upper medulla, what we call the sensory decussation, the deep sensation passing from the gracile and cuneate, crossing in the upper medulla to the other side to form the medial lemniscus, as we will see. So again, the intermediate parts, stria medullaris, separating the pons from the medulla, extending to the lateral recess. This is nothing but actually they are the posterior external arcuate fibers from the cuneate, proprioception, inferior cerebellar peduncle, not to perplex with the anterior. The anterior external arcuate fibers and the internal are not part of the floor, but I'm mentioning them not to be perplexed with the posterior external arcuate fibers. So again, this is the stria medullaris, and as we said, it extends from the cuneate to the inferior cerebellar peduncle. And this is a view, a real view. We have here the gracile and the cuneate, and these fibers arise from the cuneate and pass lateral and lateral recess on their way to the inferior cerebellar peduncle, carrying proprioception from the upper limb to the cerebellum. And this is another view, anterior view, showing the anterior brainstem. This is the pyramid, and here is the arcuate nucleus in front of the pyramid, and passing laterally in the way to the inferior cerebellar peduncle, called anterior external arcuate fibers. Anterior external arcuate fibers from the pyramid to the inferior cerebellar peduncle. Okay. These are abnormal, big external arcuate fibers are not like that, but it is for comprehension. Pyramid, pyramid, and the anterior external arcuate fibers from the arcuate nucleus from the pyramid to the inferior cerebellar peduncle. These are the internal arcuate fibers, if you remember, gracile and cuneate, sensory decussation, upper medulla, crossing to the other side, forming the medial lemniscus. So, external, internal arcuate fibers, external divided into anterior external and posterior external. The roof is tent-shaped with the superior and inferior medullary walls. Superior and inferior walls. Superior wall is formed by the superior cerebellar peduncle with the superior medullary velum. Velum is a very thin membrane covering something, like veiled ladies. So the velum, it's a membrane, thin membrane, which is the superior medullary velum, and the inferior wall of the roof is made of the inferior medullary velum. Superior medulla is with superior medullary velum, laterally superior cerebellar peduncle. Inferior part of the roof, inferior medullary velum extending laterally to the inferior cerebellar peduncle. Very easy, because how can you hold the velum? You have to hold it laterally with the cerebellar peduncle. The superior by the superior and the inferior by the inferior. And it is, what is the velum? Lined by two layers, a layer of ependyma and a layer of pia mater, forming the tella choroide of the fourth ventricle, as we'll see. So the velum is formed of two layers, one layer of ependyma and one layer of pia. The lower part of the velum has a midline opening called foramen of Magendie. Foramen of Magendie in the lower part of the inferior medullary velum. So let's have a look here. We have here again the fourth ventricle, and here is a posterior view after we removed the roof of the fourth ventricle, after we removed the villi of the fourth ventricle, and you see here that a membrane called the tella choroide membrane called tela choroide. Tela choroide, as we said, what is it? The tela choroide is the two layers of forming the tela choroide of the fourth ventricle. So when you elevate the cerebellum from behind, you get the tela choroide, and then you get the inferior medullary velum, what we call the telovelar approach. We'll see it now. Again, so this is the lateral view, and this is the lower part of the roof, and the lower part of the roof has a foramen in the inferior medullary velum called foramen of Magendie. And here, after we elevated the cerebellum upwards, here is the obex, here is the foramen of Magendie, and we have here the tela choroide, two layers, ependyma and pia, and continuing with the inferior medullary velum. We'll see it in detail. So the tela choroide is a thin membrane between the cerebellum and the lower part of the roof of the fourth ventricle, surface covering of pia mater and a deep layer of ependyma, as we said. There is also the tinea of the fourth ventricle, two narrow bands of white matter on either side, completing the lower part of the roof of the fourth ventricle. So, what is the tela choroide? Is a thin membrane between the cerebellum and the lower part of the roof of the fourth ventricle. You don't have to reach the inferior medullary velum. You see it before reaching the velum. If you lift the ventricle, the cerebellum upwards, you will find the thin membrane between the cerebellum and the lower part of the roof, and we said it is formed of two layers. But the tinea of the fourth ventricle, bands holding the choroid plexus of the fourth ventricle, like you remember that of the lateral ventricle. So again, what is this? This is, we said, the tinea choroide are a structure of white matter forming the lateral part of the lower part of the fourth ventricle. So this is the tinea choroid. It is a rhomboid shaped structure surrounded by many structures. From below, it is surrounded by the tinea choroid, and it is holding the choroid plexus. So it is forming the lower part, the lateral frame of the lower part of the fourth ventricle. It's called the tinea choroid. Here is the tela choroide. The tela choroide, when you remove the cerebellum and we went to the roof of the fourth ventricle and we are in the inferior part of it, here is the choroid plexus, and we have the first layer to reach after lifting the cerebellum upward is the tela choroid. So, choroid plexus of the fourth ventricle are two symmetrical parts forming an inverted T-shaped structure in the roof of the ventricle, protruding through its opening the median foramen of Magendie and the lateral foramen of Luschka. If you go inside them, you will see choroid plexus popping out. So this is distribution. Actually, we have a right and a left, and together we have a T-shaped structure, midline and laterally. And again, this is the distribution of the choroid plexus in the roof of the fourth ventricle. Again, foramen of Magendie. Then lateral to it is a membrane, a thin membrane, attached to the inferior cerebellar peduncles on either side and continuing upwards with the inferior medullary vela. This is the telechoroid. This part closing the lower end of the lateral ventricle is the tinichoroid. So this is after removing of the roof of the of the fourth ventricle. This is the vertical part, this is the horizontal part, right and left choroid plexuses. After that, we'll talk about the applied anatomy, and we have tumors of the fourth ventricle. The most common of them is ependymoma and medulloblastoma in children, and extending to the fourth ventricle, less commonly, you have choroid plexus papilloma and pontine tumors. As we said, more common in children than adults, and the most common approaches are the telovelar approach and the transvermian approach. This is a view of a medulloblastoma arising from the verms and filling the fourth ventricle. Medulloblastoma. And when you lift the cerebellum upwards, you will start by having a layer, which is the telechoroid, and then it continues up with the inferior medullary vela. So we call it the telovelar approach. You don't open in the verms, you just open in the telechoroid, which is extending between the inferior cerebellar peduncles and continues as the inferior medullary vela. We call it telovelar approach. Again, you find the telechoroid if you lift this cerebellum upward. A common complication, it's not common, but it happens. It has an anatomical base, that's why I mentioned it. Cerebellar mutism can occur with fourth ventricular surgery, and very strange, after 48 hours the child is normal, and then you get mutism. He can't talk, he's unable to talk, and this problem can last from weeks to months with partial or total recovery, and when they recover they have a high-pitched voice. The causes: with the telovelar approach, when you do excessive traction on the dentate nucleus, or you do an inferior vermian incision, or a big superior vermian incision. The real cause is not known, but has something to do with the dentate nucleus and traction on the fibers of the dentate nucleus going to the red nucleus and going to the thalamus. So excessive retraction in telovelar, inferior vermian incision, or big superior vermian incision can end with cerebellar mutism. So you remember that dentato rubro or dentato thalamo, when you do traction you can get this mutism. Another important clinical application of the fourth ventricle, we have the Dandy-Walker cyst and Dandy-Walker variant. Dandy-Walker malformation, as explained by Walter Dandy, is the most common posterior fossa malformation, and the original one describing hypoplasia of the verms, total hypoplasia, cystic dilatation of the fourth ventricle, and high tentorium above the level of the lambdoid suture. You know, the lambdoid sutures are above the external occipital protuberance, and here the tent reaches up to the lambdoid. And there is also Dandy-Walker variant, less severe form of Dandy-Walker. Instead of having hypoplasia, partial hypoplasia of the verms, partial obstruction, and there is no elevation of the floor of the fourth ventricle. So this is the description of the Dandy-Walker cyst, typical, described by Dandy. cystic dilatation of the fourth ventricle, high lying tent above the level of the fourth ventricle, and complete hypoplasia of the verbs. There is no verbs. This is Dandy Walker. This is a less severe form, partial loss of the worms, attenuation of the fourth ventricle, and there is no elevation above the tent. So, cystic dilatation, but with some worms present and without elevation of the tent. Dandy Walker variant. And the differential diagnosis of the Dandy Walker cyst is from the cerebellar vermian hypoplasia. Sometimes you get hypoplasia of the worms, and sometimes you get megacisterna magna. How can you differentiate between the three radiologically? The Dandy Walker malformation, as we said, small or absent worms. Rotation of the worms, it is horizontal instead of being vertical, and very big posterior fossa with elevation of the tent. Cerebellar vermian hypoplasia, we get partial affection of the worms without rotation and normal posterior fossa. So the cerebellar hypoplasia is what we call the Dandy Walker variant. It's the same. And the megacisterna magna, in this case, it is behind the cerebellum. We get normal worms, we get no rotation, and we get also big posterior fossa. So the big posterior fossa is present in Dandy Walker malformation and in the megacisterna magna. In cerebellar vermian hypoplasia or Dandy Walker variant, there is no big posterior fossa, it is normal, and there is no rotation. But in Dandy Walker and Dandy Walker variant, we have small worms. In megacisterna magna, of course, we have normal worms. Hemifacial spasm also has something to do with the facial nerve and the root exit zone, because the root exit zone is identified by going subcerebellar, lifting the flocculus up at the same line, 9, 10, and 11 cranial nerves. So facial nerve and the cochlear are on the same vertical line. Above 9, 10, and 11, if you lift the flocculus up, you can reach them. Root exit zone, as you can see, and you can also do it by retracting the cerebellum medially. Sometimes you lift the cerebellum up, sometimes you do it medially, both work. This is the hemifacial spasm. This is the opening for the hemifacial spasm. And this is the pad of fat we put at the root exit zone of the facial nerve at the brainstem. And this is, we are retracting the flocculus. We are retracting the flocculus backwards, which is the posterior wall of the lateral recess of the fourth ventricle. And this is a view, an endoscopic view, showing 7 and 8, and the pica forming a loop, affecting the 7s from below, and here is the cause for the hemifacial spasm. Also, there is something called brainstem implants related to the fourth ventricle, very important in neurofibromatosis type 2, central type of neurofibromatosis, bilateral vestibular schwannoma. If the bilateral cochlear functions are lost, we put inside the lateral recess of the fourth ventricle, in front of the flocculus and choroid plexus, through the foramen of Luschka, over the cochlear nucleus. So this is the apparatus or the device. You shouldn't know all the details, but you should know that something called brainstem implant can be put in cases of NF2 with total loss of cochlear nerves. And as we said, the cochlear nucleus is here. So in front, in the foramen of Luschka, in front of the flocculus, behind the inferior cerebellar peduncle is, we remember the vestibular area, when we said the vestibular area is present above and below the stria medullaris, and the cochlear nucleus is present with the vestibular area. So we are putting the electrode directly over the cochlear nucleus in the foramen of Luschka. So this is the cerebellum, retracted medially. This is the right side, 7 and 8, 6 more medially, and 9, 10, and 11. And we put our piece here where the cochlear nucleus will be present. Thank you very much for your attention, and we hope we meet soon with another interesting subject in our series of applied neuroanatomy. Have a nice day. Thank you.